Good evening, everyone, and welcome to the webinar on treatment dilemmas in lung cancer and update. It gives me great pleasure to invite our program director, Dr. Poonam Patil, senior medical oncologist from Manipal Hospital, Bengaluru, to give the opening remarks. Over to you, ma'am.
So thank you very much. A very good evening to you all. It's a privilege to welcome you to the Symposium on Treatment Dilemmas for EGFR mutated metastatic lung cancer. As we know, the landscape of lung cancer treatment has evolved significantly with the advent of targeted therapies, particularly the EGFR tyrosine kinase inhibitors. However, despite these advancements, we continue to face challenges such as the choice of drugs, acquired resistance, and disease progression. So today we will delve into these complexities, explore the emerging therapeutic strategies, address the gaps in the knowledge and practices, and discuss how we can optimize patient outcomes in this rapidly changing field. So today we have two talks. There will be one Indian perspective on EGFR mutated non-small cell lung cancers talk given by Dr. Aditya Murali. And then this will be followed by international speaker program with a talk by Dr. Pasi. And this will be followed by a panel discussion, a case-based panel discussion. So I welcome Dr. Aditya Murali to begin today's session. He's a senior consultant in medical and hemato-oncology at Apollo Hospitals, Bengaluru, and he will be speaking to us about Indian perspective on EGFR mutation in non-small cell lung cancer. Welcome, Dr. Aditya.
Thanks, ma'am, for the opportunity, and I'd like to thank AstraZeneca for getting us all on board. Today, I hope to learn a lot from our international speaker, and already even prior to this, preparing for the talk today. This is a unique talk because I got to see some very interesting data which I had not seen before, and got to learn quite a bit from that. So over the next 8 to 10 minutes, I'll talk on an interesting topic about how the Indian perspective on EGFR mutations has changed in non-small cell lung cancer. So the initial part of the talk is based primarily on Dr. Naronia et al.'s work, which was published in Lancet 2024. A lot of this data came from TMH Mumbai. This slide basically talks about, when we look at non-small cell lung cancers in general, about 40% of the patients who were included in this study from TMH had adenocarcinoma and 30% had squamous cell carcinoma. Now we know from the previous data, especially a lot of epidemiological studies have been done from PGI Chandigarh, and in that probably the proportion of adenocarcinoma was slightly higher, the proportion of squamous cell carcinoma was lower, but in this study squamous cell carcinoma constituted 30% of the patients. When we looked at the adenocarcinoma bit, nearly a third of the patients had some kind of a EGFR mutation. When we looked at the relative prevalence of the mutations amongst males, female smokers, and non-smokers, as expected, the incidence of EGFR mutation in non-smokers was much higher. And in women, the 51% of the women had a EGFR mutation as compared to 35.1%. But all in all, this whole number added up to about 30%. This is a very interesting slide which talks about the statewide distribution and the patterns of prevalence of EGFR mutations across the country. We know that the testing platforms are very, very robust in Maharashtra, and they were able to pick up about 28.6% of the patients of non-small cell lung cancer who ended up having EGFR mutations. Karnataka did show about 20%. Interestingly, in the Northeast, 30.8% of the patients with non-small cell lung cancer did end up diagnosing to have a EGFR mutation. And this is even more peculiar and worth learning from, because the prevalence of tobacco use is actually far higher in the northeastern part of our country compared to many other parts. So contrasting that with a state like Madhya Pradesh or Rajasthan, wherein just about a fifth of the patients had EGFR mutation. It's a very interesting statistic to learn from. And when we break down the exact subtype of the EGFR mutation, as expected, the exon 19 deletion did constitute about half of all the EGFR mutations detected. Then came the exon 21 L858R mutation. Exon 20 insertions. Now we have this drug. People want to know what the prevalence is. Not very high. In this study, the exon 20 insertions population was just about 0.7%. So when we contrast this with some of the other data which was published, Dr. Chogle's group published a data as early as 2013. Around 950 patients were there in 900 odd patients were there in this paper, and of the 900 odd patients in 2013, 23% of them had some kind of a EGFR mutation. And mind you, this number comes from PCR based platforms. There was another study which was published by Dole sir which looked at patients between 2015 and 19, which showed a much higher prevalence of about 32 to 39%. And from Dr. Naronia's group, the prevalence was 43%. So one of the reasons which can be attributed to this higher prevalence or higher pickup rate of EGFR mutations is improved testing rates and improved technologies, especially the use of NGS. And I'll talk about this a little bit more in this slide. So when we use PCR as the platform for EGFR mutation testing, the TAT is not so high. So across the labs in the country, the turnaround time for a PCR based test is about a week or so, 5 to 7 days. We do end up getting the results. The tumor content required in the tissue is about 5%, and it is less expensive because it uses only hotspots. But the biggest problem of using a hotspot PCR based testing is that it does not detect mutations in other genes. There are certain centers in India, even in Bangalore, there is a center wherein we are able to do something called a single fragment sequencing. So if there is a patient in whom we want like a express report, I know there is nothing emergency in a non-small cell lung cancer, but if we need an express report, there is an ability to do a single DNA fragment sequencing. The big drawback of this, the good part is we get a report in 24 hours. I think the lab which I am referring to in Bangalore gives us the report in 48 hours. But the problem with this is that it requires more than 30% tumor content, and quite often in lung cancers, tissue is always an issue, and there's also a multi-step labor intensive process. Standardizations is tough, and we also need to factor in the cost part of it. I think across most tier 1 cities in India, we have moved to a NGS platform wherein the turnaround time is, I wouldn't say 10 days, turnaround time is 2.5 to 3 weeks. The good part of this is that, the amount of tumor tissue needed is not too much. So if we have just a small bit of tissue remaining, we can confidently send it for a NGS based testing with having the comfort that we will get relevant reports. Expenses is, it is relative. There are industry colleagues who are partnering with companies, and now many of them have this limited NGS panels which are available either at a free of cost or at a highly subsidized discounted rate. So expense is not too high when we are doing a limited panel. Availability in tier 1 cities is very good, but in tier 2 peripheral centers, it is not there. And hence, many of them still fall back on the PCR platform. And that's because this does require quite a bit of technical expertise. I think the biggest reason why NGS is preferred over PCR for actionable driver mutations, especially and including EGFR, is that NGS detected driver mutations in 38.7% of the patients that were missed by real-time PCRs. And out of this, 11.3% were actually EGFR mutations. So especially if we have a patient whose clinical profile fits into some kind of finding, some kind of actionable driver mutation, it's very important for us to try and push for the NGS testing, because even if, I mean, missing 10% of the EGFR positive non-small cell lung cancer patients is a big number. They miss out on potentially extremely effective, less toxic therapies. And today's day and age, I think there is no reason for us to not try and do an NGS based testing in most of the big hospitals in Taiwan City. So with NGS, simultaneous testing of multiple genes can allow optimal utilization of the available tissue, which is especially important in lung cancer. So NGS has a number of advantages over single gene tests. The biggest one is that a broad range of molecular alterations are diagnosed in a single sample. It may even identify, if we do a wide open NGS system, then we may identify new markers that could offer additional treatment options for a patient and or provide information to help the development of new and more effective treatments. When we look at the cons of using an NGS versus a single gene test, I think the biggest issue is the availability due to the high complexity of the workflow. And one thing which is not mentioned here is the turnaround time. Waiting three weeks is still a very big deal for many of our patients. So I think this is one of the standout slides of the presentation, in the sense that this how many and this was a multi-center survey published by Dr. Kumar Prabhash and his group. This looked at centers which had in-house testing facility versus centers who had their testing outsourced. If a patient went to a center with an in-house testing facility, nearly 70% of the time, the treating oncologist actually waited for the NGS reports to come. And that's also because if you have in-house testing, almost always by day 12 or day 14, you are going to get the report, and waiting for 12 to 14 days is actually not such a difficult thing trying to convince the patient. However, if you are at a center wherein the testing is outsourced, about half the time, oncologists were probably going to start treatment even before the testing reports came out. At least maybe give a dose of give one cycle of chemotherapy, or wait, or at least try something before we get all the molecular answers. And this data, which was published in ASCO, Journal of Oncology Clinical Practice, it clearly showed that the outcomes were compromised if we did not wait for the actual actionable mutation. So this was, although this was a retrospective analysis, but this included real world data. And for patients harboring actionable mutations, initial treatment before the receipt of genomic test results yields significantly inferior outcomes. And I think all of this also reinforces the philosophy that at large volume centers, we should try and push for more in-house testing facilities. This slide talks basically about the 1 second, sorry. I opened some screen. Let me try and see how to. Okay, yeah. So this slide basically talks about the prevalence of EGFR mutations in early stage non-small cell lung cancer. This was presented at ASCO 2023. So if we test, and I think now routinely all of us are testing for EGFR mutations even in earlier stage non-small cell lung cancer. So in this, the EGFR mutation prevalence was nearly 50%, and we know that now we have a TKI in the form of osimertinib, which is approved for usage even in the adjuvant setting. So it's very important for us to test for EGFR mutations across all stages of non-small cell lung cancer. I think this slide nails it in terms of the comparison of NGS versus PCR-based concordance. If we do all three, if we try and see all three subtypes of EGFR, the concordance rates were about 82.9%. The sensitivity of NGS is better, the specificity is better, and this just both the positive and the negative prediction values are better. It underlines the fact that using NGS is very important. The NCCN endorses liquid and tissue biopsies concurrently. Now, I understand, and we all face this problem in the clinic, that ordering both the liquid and the tissue biopsy can be extremely expensive for the patient. However, in certain very rare cases, if the patient is unfit for clinic or for invasive sampling, and or more likely insufficient tissue available, especially in patients who've got pleural effusions, we do a cytology, the cytology turns out to be positive, but we don't have enough tissue for a tissue based NGS. In such a scenario, ctDNA or liquid biopsies can be done. This has been endorsed in NCCN 2024. If we try and compare the tumor tissue versus the liquid biopsy, the sample acquisition for liquid biopsy includes just about a simple blood draw of about 10 ml of whole blood. In terms of analytical standardization, standards for analytical performance of characteristics of cell-free DNA, ctDNA have not very much been established, and no guidelines exist regarding the recommended performance characteristics of liquid biopsy. So, in terms of evidence of clinical utility, the utility here is probably less, but there is increasing evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure. I think one of the widest applications of liquid biopsy is if a patient progresses on first-line therapy with actionable driver mutations, and in such a scenario, repeating an NGS can yield potential resistance mechanisms. I think in terms of sensitivity, there is always a worry whether it's sensitive enough or not. Liquid biopsies are very sensitive. Required ctDNA may comprise of less than 0.1% of cell-free DNA. The only problem is that the direct correlation between the ctDNA results with the histology or cell type is not possible, and still we should try our very best to obtain a tumor tissue when we are talking about treatment of non-small cell lung cancer. So, in terms of testing recommendations for advanced lung cancer, I think it's very clear cut. An NGS is done especially to look for most of the actionable driver mutations, along with the testing for PDL1. If a driver mutation is detected, the approved targeted therapy has to be used. If there is no genetic driver mutation, then all of the other criteria, especially PDL1 and tumor mutation burden, do come into place. If a EGFR mutation turns out to be positive, that makes the prevalence of the PDL1 percentage not relevant at all. As long as we have a EGFR mutation positive, even if PDL1 is higher than 50%, it does not matter. The TKIs are the way to go. I thank you all for a patient listening, and I hope to learn a lot from our international speaker. Thank you.
Thank you very much, Dr. Aditya. And that was really a very insightful talk about what's the real world scenario in India and how things are, what is the status in India. So what is your practice now? Would you wait for the results, or would you start chemotherapy? And now with the combination of TKIs and chemotherapy, would it be wrong to start chemotherapy without waiting for the TKI result?
I think over the last 6-8 months, given the combination data which we have had, this decision is not so tough. So to answer your question, about a year ago, I tried my level best to wait for the reports to come in and only then start. But now at least we have data for combination of TKI chemo. So we do go ahead and start off with pemetrexed carboplatin. We are very certain, even if the PDL1 reports, the IHC comes in a day or two saying that it's 50-60%, we do not act on that. We just give the chemotherapy. Based on the presence or absence of driver mutation, further treatment decisions are made, ma'am.
And what about PDL1 positive status? Also, you would still wait for the NGS reports before you add on immunotherapy?
On that count, we really do wait. Even if we think the possibility of a driver mutation is low, we still wait to get the NGS reports, because almost always we do get it prior to the next cycle. So it's not like there is no tearing hurry of starting a immunotherapy, ma'am.
Thank you very much, Dr. Aditya. We have Dr. Pasi with us. I can see him.
Hello. Hi, how are you?
Yeah, good. Pasi. So welcome, Dr. Pasi. Today we have Dr. Pasi amongst us all, who will be taking us through an update of treatment dilemmas in lung cancer. And Dr. Pasi has been the Senior Vice President for Translational Medicine and the Scientific Director of the Belfer Center for Applied Science at Dana-Farber Cancer Institute and Professor at Harvard Medical School. He has obtained his medical degree and doctorate from University of Pennsylvania and completed postgraduate training and in internal medicine at Brigham and Women's Hospital and a fellowship in hematology and oncology at the famous Dana-Farber Center. His main research interests include studying the therapeutic relevance of oncogenic alterations in lung cancer, and he was one of the co-discoverers of EGFR mutations and has led the development of therapeutic strategies for patients with EGFR mutant lung cancer. He was recently awarded the American Cancer Society 2024 Medal of Honor, and the Medal of Honor is the American Cancer Society's most prestigious award bestowed to distinguished individuals or foundations who have made valuable contributions. Dr. Pasi, we are extremely privileged to have you amongst us today. I invite you to go ahead with your talk.
Sure. Thank you. And it's a pleasure to be here. Let me share my screen here. And which version can you see? Can you see the full version or the presenter mode?
So we can see the full version, sir.
Okay, perfect. So we'll go with that. Great. Thank you again for the invitation, and I'm happy to talk to everyone about advanced EGFR mutant lung cancer. This is, of course, a area where we've had some advances in the last several years, and it continues to be an exciting time for thinking about therapies for our patients. These are my disclosures. So if we look at the guidelines and the NCCN guidelines, which are, of course, what we follow in the US, for patients who are discovered to have one of the common EGFR mutations, the exon 19 deletion or 21, the first-line therapy, there are multiple first-line therapeutic options, but osimertinib is the preferred choice here as the first-line therapy in patients who it's discovered prior to the start of systemic therapy. ESMO guidelines are similarly recommend osimertinib as the treatment of choice for first-line advanced EGFR mutant lung cancer. And this is, of course, based on the FLORA trial where osimertinib was compared to standard of care EGFR TKI, a choice of either gefitinib or erlotinib, and shown to have an improvement in both progression-free survival as well as overall survival. It's approved as first-line therapy for advanced EGFR mutant lung cancer and for patients who develop EGFR T790M-mediated resistance to prior EGFR TKIs, as well as in the adjuvant setting for patients who have had early-stage resected EGFR mutant non-small cell lung cancer. And this year at ASCO, we saw the impressive data for patients who've had locally advanced lung cancer treated with chemotherapy and radiation with EGFR mutant cancers. Adjuvant osimertinib there led to a dramatic improvement in disease-free survival. However, one of the problems is that we don't cure anyone with osimertinib with EGFR mutant lung cancer. And it's because resistance inevitably develops. And you can think of resistance as coming from a couple of different categories. One is pre-selection of a resistance mutation, and this is much better described for earlier generation EGFR inhibitors where EGFR T790M, the common resistance mutation, can exist baseline and be selected over time with treatment leading to a frankly resistant cancer. Or the second model is where there really isn't a pre-existing resistance mutation, treat someone with a targeted therapy like osimertinib, And you develop this intermediate state, this persistent state, this drug-tolerant persistent state, a state that where cancer cells are able to survive despite EGFR inhibition. And out of this state, you get a wide variety of different resistance mechanisms can arise. And this is probably, in my mind, the more common, at least what we're common path to resistance, at least what we're seeing for osimertinib. And so how do we deal with that? So we can develop something that would enhance the effect of EGFR targeted therapy to ultimately reduce or eliminate this intermediate state and as such, hopefully delay resistance. Or we can ask, are there unique vulnerabilities of this intermediate state that we could specifically go after? And so let's talk about the first approach, and that this is partly along with clinical data from prior studies, what led to the idea of adding chemotherapy to osimertinib, in that may synergistically delay resistance by enhancing cell killing of different populations of cells and lead to a greater overall efficacy compared to monotherapy. And chemotherapy and gefitinib, of course, have been studied previously, including in India in a phase 3 clinical trial showing improvement in PFS and OS, as well as in Japan, showing that specifically this combination in EGFR mutant patients could be beneficial. And so this is what led to the FLAURA2 trial. Patients advanced EGFR mutant non-small cell lung cancer with the common EGFR mutations were treated either with osimertinib alone or the combination of platinum-based chemotherapy for 4 cycles followed by maintenance pemetrexed, all in conjunction with osimertinib. And the primary endpoint here was progression-free survival. And this was a positive study. It led to about a 9-month improvement or so in progression-free survival. And you can see here a 24 osimertinib are alive and without progression compared to those patients that received osimertinib alone. And you can see that the hazard ratio is 0.62 and highly statistically significant. Now, if we look at different patient subsets, patients with CNS metastases, this is now systemic PFS, really had a very significant improvement in their PFS. Even without CNS metastases, that was the case. And this was also the case that chemotherapy added to both the efficacy in patients with exon 19 deletion or the L858R mutation. We sometimes think of the L858R mutation as the not as good EGFR mutation because in the FLAURA trial, for example, there was no survival benefit in that patient subset. And sometimes the benefits of EGFR inhibitors are different between those two common mutations, and they usually always favor the exon 19 deletion. So it's nice to see that chemotherapy added to both here. And this was the combination received US regulatory approval in February of this year. Now, there have been some interim analyses of the overall survival. This is the most recent of it, suggesting this is not statistically significant yet, and the maturity is still quite low, that there may be an overall survival benefit, but we won't know that for quite some time until all of the survival events have happened, and that's not anticipated for quite some time. But a suggestion with a hazard ratio of 0.75 that, and you can see the curves nicely separating. Now, what about response rates? Response rates were very similar, a little bit higher with chemotherapy, 83 versus 76%. But it was the duration of the response that was markedly different. 24 months with chemotherapy, osimertinib, 15 months with osimertinib alone. Now, this is the CNS progression-free survival. And one of the sort of surprises from this trial was that chemotherapy added to CNS efficacy. Now, we know that osimertinib is a highly CNS penetrant drug and sometimes used to treat patients with brain metastases to avoid the need for radiation. But here, when we added chemotherapy, the CNS PFS was also improved in all the full analysis set, or on the right-hand side for patients that were evaluable for response. You can see the hazard ratios there. And these are the CNS responses. On the left, the chemotherapy, osimertinib, you can see many more patients with complete responses in the dark blue compared to osimertinib alone. Again, something in the duration of response here had not been reached yet. So something that we didn't completely anticipate from the beginning, but certainly I think the clinical data demonstrate that. If you look at patients who didn't have CNS disease and look at over time, CNS progression, these dotted lines, patients with osimertinib in blue are more likely to develop CNS progression. For example, 24 months was 23% with osimertinib alone at 24 months, compared to only 9% with patients who'd received chemotherapy and osimertinib. So adding chemotherapy was not only more effective at treating CNS disease, but also preventing emergence of new CNS disease. Now, combination doesn't come without side effects. And here, most of the side effects are chemotherapy side effects. There were no new side effects of adding osimertinib to chemotherapy. So there are anemia, diarrhea, nausea, neutropenia, thrombocytopenia, things that we typically associate with carboplatin and pemetrexed. And there are some cases of febrile neutropenia. Interestingly, we of course know that interstitial lung disease or pneumonitis is something that we occasionally see with osimertinib, and it wasn't any different. It was 3% in the chemo combo arm and 4% with osimertinib alone. So it didn't increase the likelihood of pneumonitis. And here, the side effects are kind of displayed in a different sort of way over time. And of course, you can imagine in blue is the combination chemotherapy part. And you can appreciate that things like hematologic toxicity, diarrhea, fatigue, et cetera, are higher while getting combination platinum-based chemotherapy. And then over time, as you transition to single agent pemetrexed, they get less. And that is indeed the case. Blue, and then 3 to 9 months or greater than 9 months would be during the time of maintenance chemotherapy. One of the things that, and we'll talk about is who do we give combination therapy to? And is there a way to figure out who should get chemotherapy and osimertinib and who should get just osimertinib alone? And I will say we don't have a clear answer to that. And there's a couple of things that have been looked at. This was looking at baseline ctDNA where you can detect an EGFR mutation. And in general, that is a poor prognosis population. And if you can detect ctDNA on the left-hand side at baseline, patients do better if they get chemotherapy and osimertinib. If you can't detect ctDNA, which is a good prognostic sign, there is a little bit of a difference by adding chemotherapy, but not as but still single agent osimertinib also works quite well. And so you could potentially use something like this to stratify or decide if someone should get combination therapy versus not. The other thing, which is fairly new, is looking at co-mutation status. For example, P53, which is felt to be associated with poor prognosis. And on the left-hand side are patients that do not have a P53 mutation. And on the right-hand side, ones who have a P53 mutation. These are all done from tissue sequencing at baseline. So you can see, for example, compare the solid blue to the dotted blue. So having a p53 mutation is associated with a poorer prognosis than not. If you, in red is the combination of chemotherapy, and it improves outcome if you have a p53 mutation, but it also improves outcome if you don't. So this is not, the p53 mutation is not a clear determinant of somebody who needs chemotherapy in addition to osimertinib, since it adds to both populations. Now, this isn't the only intensified clinical trial. We also have data, of course, on the Mariposa phase 3 clinical trial, which evaluated a different approach, looking at amivantamab, a bispecific EGFR MET antibody, with lazertinib, a drug that's very similar to osimertinib, compared to osimertinib or lazertinib. Here, too, the combination of amivantamab and lazertinib led to an improvement in PFS over osimertinib alone. Here, about a 7-month improvement, but still highly statistically significant. It does come with very different types of toxicities, and this is not a easy combination to give. There's a fairly high rate of discontinuation, 35%. There are grade 3 and higher AEs in the vast majority of patients. And the side effects here are really on-target toxicities. And what I mean by that is on-target EGFR toxicities in normal tissues: paronychia, rash, diarrhea, dermatitis, stomatitis. Also MET-related toxicities, hypoalbuminemia, peripheral edema, as well as others. So you can see on the left-hand side of the combination, on the right-hand, single agent osimertinib. Pneumonitis, again, in this combination was similar in both arms. So it's nice to see, and it's an important clinical question. If you add something to osimertinib, does it increase pneumonitis? For example, we know that we cannot add immune checkpoint inhibitors to osimertinib because it increases the rate of ILD by tenfold. So getting to, so sort of thinking about this on a bigger scale, first line EGFR combination versus single agent. It's a balance of efficacy versus toxicity. So I talk to my patients. The Mariposa regimen was recently approved in the US, although I have not used it myself. I've used amivantamab, but not with lazertinib. So when I'm talking about combination therapies, mostly to patients, it's about chemotherapy versus single agent osimertinib. And I talk about the efficacy differences, but also, of course, the toxicity differences. Similarly, things that impact this are things like having to come to the clinic every 3 weeks for IV infusions versus taking an oral agent at home. It are not so much for chemotherapy, but drug availability and reimbursement may factor into the choices of a combination versus single agent. And I still think there's room for novel combination therapeutic approaches. Although I think the FLAURA2 and Mariposa trials showed the proof of principle that a combination can be better than a single agent, there are toxicities and limitations, and we can hopefully do better with other combinations that would be better tolerated. Who needs this therapy? As I mentioned, we looked at p53 mutations, baseline ctDNA, having EGFR L858R, having CNS metastases at baseline, or having a higher disease burden. Are these factors that would go into the decision of using combination versus single agent? As I said, at the moment, it's a conversation between the provider and the patient. And ultimately, when is the best time to do a combination? Is it from the start of therapy? Is it following a maximal response to an EGFR TKI, or is it at the time of resistance to osimertinib? I think questions we don't still completely understand. So I wanted to just illustrate a few examples of some real-life questions, real-life cases of thinking about using combination approaches. This first one is a patient of mine. It's a 60-year-old gentleman with advanced EGFR mutant lung cancer. He was symptomatic, presented with cough, chest discomfort, weight loss, had fairly extensive disease, lung, lymph nodes, bilateral adrenals, liver, no CNS metastases, had a exon 19 deletion, EGFR, slightly atypical one, and a p53 mutation. This, you can see his scan with his collapsed right upper lobe. I discussed with him about using chemotherapy in combination with osimertinib, just given the nature of and extent of his disease, and he was symptomatic, and he was agreeable to that, so we did treat him. And then this is after 4 cycles of chemotherapy, osimertinib, and you can see this mass has decreased nicely, and the right upper lobe has opened up some more. There's another view of that same right upper lobe mass, and then how it's shrunk after 4 cycles of treatment. This is a second case of a young woman with EGFR mutated advanced non-small cell lung cancer. She presented with left groin pain and right-sided back pain, has disease in the lungs and the bones, has the more common EGFR exon 19 deletion and MYC amplification, which we don't know that it means anything at this point, but something to think about for the future. This is her PET CT, and you can see she has disease in essentially every vertebral body, but most notably in the pelvis. And she did not want to come in for IV infusions. She had young children at home. She wanted to spend time with them. She wanted to do single agent osimertinib. I discussed with her about chemotherapy as well, but she was not interested in that. And she started single agent osimertinib. Her bone pain markedly improved, and she was off pain medications. And this is her follow-up PET CT, and you can see clearance of all of the vertebral body metastases, and as well as metastases in the pelvis. And so she's had a very nice response to single agent osimertinib. And again, an illustration that you don't always need chemotherapy to get these kinds of responses. They can happen relatively quickly with single agent osimertinib. And in her, what I mentioned about ctDNA, in her, we did a baseline ctDNA, and the ctDNA of the EGFR mutation allelic fraction was exceedingly high. And you can see here 27.8%. And after 6 weeks of osimertinib, it became non-detectable. We know that if you clear your ctDNA, that is a good prognostic sign overall. Whereas if you don't, that's associated with poor prognosis. And in fact, there's a clinical trial ongoing being conducted by my colleague Helena Yu at Memorial Sloan Kettering, whereby patients who start with detectable ctDNA don't clear their ctDNA are then randomly assigned to continue osimertinib or the addition of chemotherapy to ask sort of midway or part way through treatment, does intensification of therapy help at that juncture? Another case, here we don't have an answer, but a lady who presented, smoking history, presented with dysphagia, weight loss, had a left lower lobe lung mass, extensive lymphadenopathy, abdominal lymphadenopathy, and here you can see numerous CNS metastases. And again, by liquid biopsy, had an EGFR exon 19 deletion. She ultimately opted for single agent osimertinib as well, and you can see a very nice improvement of the CNS metastases. This is not my own patient, but in this case, with all the CNS disease and extensive systemic disease, I would have probably favored the combination treatment, but for whatever reason, she did not, and she's done well with single agent osimertinib. So that was what I wanted to present today, and I'm happy to take any questions.
So that was really an excellent presentation, sir. And you really brought out all the points and you clarified and made the data easy to understand. Thank you very much. I saw that you assess all the patients at 6 weeks after starting osimertinib.
Yes, typically for us, because it also coincides with 2 cycles of chemotherapy, which is our normal assessment time. So typically about 6 weeks is when we'd assess, but we usually see them, you know, if we start somebody on osimertinib, we'll usually see them back in 2 weeks just to make sure that, are they tolerating the medicine? If they had any symptoms prior to starting therapy, have their symptoms improved? And just to make sure there's no laboratory abnormalities such as LFT abnormalities, which you can sometimes see with osimertinib.
Okay, anyone has any questions? Or shall we take it in the next panel discussion? I don't see any questions. So we now move on to the next talk, which is a panel discussion, a case-based discussion, challenges in the management of EGFR mutated non-small cell lung cancer, which will be moderated by Dr. Krishna Prasad. He's a senior medical oncologist from Mangalore, and his esteemed panelists would be Dr. Pasi, Dr. Anita Ramesh, Dr. Arun Warrior, Dr. Rakesh, and Dr. Aditya Murali. Welcome you all. Dr. Krishna Prasad, please take over.
Thank you, madam. Is the screen visible?
Yes.
Yeah.
Yes.
So I think I thank AstraZeneca for this opportunity, and I'm honored to have these extreme panelists with me. So let's start with a 65-year-old male patient, non-smoker, presented with cough and pleuritic chest pain of 1 month duration. And the CT scan showed a left lower lobe mass 5.5 centimeter invading the pleura, multiple small para-aortic lymph nodes, left hilar lymph nodes, and pleural effusion. And when we did the PET CT, there was multiple disease in the bone, liver, and brain. So biopsy came as adenocarcinoma, TTF1 napsin positive, and the NGS came as EGFR exon 21 L858R mutation. So in your routine practice, if you can start with Arun, what is your preferred line of management? What has it been in the last 1 or 2 years? And have you changed recently? Arun, are you there?
So you will have to unmute your mic.
Yeah, first. Yeah. Can you hear me now? Yeah. So, hello?
Yes, Arun.
Yeah. So basically, if someone comes with adenocarcinoma, so we would like to go for the mutation first. But the practical issue, we need at least 2 to 3 weeks time. So even though Dr. Aditya told that there is a study showing that may not be the ideal, but we practically end up starting them on some form of treatment first and then wait for the reports. That's what we are doing.
Okay. Are you starting chemotherapy alone or chemo plus immunotherapy?
No, alone. Yeah, chemo alone. Because if they are mutant, then immuno won't be the best thing. So we start them on chemo first and then wait for the NG. That's the practice.
Fair enough. In this particular patient, the NGS has come as EGFR positive L858R. What would your choice be in this given list?
Yeah. Yeah, if the EGFR mutation is there, then definitely the first choice will be osimertinib, and we are discussing about this with our patient. But then again, practically, some of them may not be able to afford the drug. So then we have to discuss about the other options.
Okay. Dr. Rakesh, in your practice, what is your preferred line of management? And what is the common management you actually do on the ground?
So preferred, I think there are multiple options for this patient. All the options which are listed here are obviously valid for this particular patient. We need to go into the granular data of the subgroup analysis, which may not be completely scientific. Looking at the mutation that we have with this patient, the L858R obviously is not going to be as responsive as the deletion 19. And with the presence of brain metastasis, obviously the choice is between osimertinib monotherapy versus osimertinib plus chemotherapy. That would be the most obvious. And in the Indian scenario, if the osimertinib is something that we really have to look at the financial part of it, a better compromise will be a gefnib plus chemotherapy. So, but scientifically speaking, both monotherapy and osimertinib monotherapy plus chemotherapy is the preferred choices for me. If the patient is fit enough and willing to take some chemotherapy, probably the osimertinib plus chemotherapy is the choice that would put on the front line. and followed by osimertinib, followed by geftinib plus chemotherapy, and finally geftinib alone. That's what I would do.
Fair enough. Dr. Anita, madam, what is your choice in these patients? And actually, practically speaking, what percentage actually get your choice? And if they cannot afford that, what would your next option be? Madam, you are still muted. Still muted, madam. Organizers, can you unmute, madam? I think she's having difficulty in unmuting. Yes. Now.
Yeah, okay. Yes, sir. The choice will differ. Choice is osimertinib. It will be my first choice. Yes. And basically monotherapy, if there's a mutation present, yes, osimertinib therapy. But yes, I do go for geftinib and chemotherapy, particularly when I'm in the medical college, where the choices are limited because of logistics. Geftinib and chemotherapy will be my first choice. I do also give second generation like alatinib and even afatinib. I do use, because again in the medical college, the first two option holds good for 80% of my patient because of logistics. Yes, in an ideal situation, when no logistics plays, I would like to use the drug osimertinib. Second choice, alatinib ramucirumab, is also an approved option, and the third option is also correct. But preferably, the first is osimertinib monotherapy.
So in this patient, madam, who has brain metastasis also, so if you're planning, say, geftinib plus chemotherapy, when would you think about using radiation to the brain?
Yeah, even if it depends upon what is your rate, what is your brain mets. It's asymptomatic, we don't get into any radiation. But if the patient is having headache, features of papilledema, raised intracranial tension, yes, we do start with steroid immediately. We bring in the radiation oncologist, a smaller lesion, fewer lesions, yes, symptomatic, SPRT, otherwise multiple lesions all over the brain. I do start the extra EBRT to the whole brain, because that also ruptures your blood-brain barrier and allows many of the drugs to penetrate. But if you're using osimertinib upfront, it will automatically penetrate. But if you're going with the first and second choice, you might need radiation to be given to the whole brain, and so the drug penetration is higher and the effects are better.
Aditya, what about you here in your practice? What is your usual go-to drug? And what percentage of your patients actually get what you desire?
Generally, sir, about 50 to 60% of the patients are able to afford osimertinib, perks of being in a tertiary care center. But I do try and use the combination, as Dr. Arun said, most of the times what I would end up doing is start them on chemotherapy. And if we do have the target mutation positive, then offer osimertinib at least. I think one of the things which I also want to learn from everyone is, I think recently, about a week or two back, there was some data which got published, which said that if the number of mets in the brain were fewer, and if they were amenable to SRS, I think the CNS PFS was better, even if we were able to give the latest generation TKIs. And this is something which I want to learn from this esteemed group, sir.
Fair enough. So I think we will get Dr. Pasi's opinion on two questions. One, sir, when would you actually use a combination of EGFR TKI plus VEGF inhibitor? Are you using it at all in your practice? And secondly, the role of radiation to the brain, SRS.
So in terms of EGFR inhibitors, we are not using them at all. And because most of the data that is positive exists with the prior generation EGFR inhibitors, I realize that, and the data that's out there with osimertinib in combination is essentially all negative. There's not a single positive trial, with the exception of a small MD Anderson trial that was presented last year, but that seems like an outlier. Radiation, typically for single or a few metastases, I have the patient see the radiation oncologist first to think about SRS. Most of the time, if they have an EGFR mutation, we do go straight ahead with systemic treatment with osimertinib because it can get into the brain very well. But there are, of course, instances where by we need to do radiation. I try to avoid whole brain radiation if possible, just because of the symptoms or the side effects of whole brain radiation. But certainly progressing in the brain with a solitary lesion or having a more dominant solitary lesion, those may be reasons our radiation oncologists would do stereotactic radiation.
And I gather most of those radiation are progression on osimertinib or upfront as well?
Typically progression. Because upfront osimertinib works very well. Now, sometimes if you have a large lesion and or even multiple lesions, you treat the patient and they don't go away, they're still present, then there's sort of then that would be another time I would consult with our radiation oncologist to ask that if a lesion is sort of partly treated but not completely treated, would that be a time to then add radiation to that specific residual lesion? And I would say I don't think there's a clear answer one way or the other. I think it depends a little bit on the radiation oncologist as well as the clinical situation of the patient.
Fair enough. So I think this patient was taken up for single agent osimertinib, even though the discussion was osimertinib plus chemotherapy based on the FLORA-2 study. I'd like, Arun, your thoughts on this. I think this is an analysis of that to suggest that patients with more than 3 or more metastases at baseline had maybe a slightly better benefit compared to somebody with little less disease. What's your thoughts, Arun?
So I feel that even with the CNS, that's what I've actually seen. So generally nowadays, SRS is being increasingly used, and we feel that the toxins are also lesser with them.
Okay.
So
What about this thought that if there are 3 or more metastatic sites at baseline, that means somebody with maybe higher tumor burden, maybe the benefit of adding chemotherapy is slightly higher?
So not very sure, because generally what we feel is that for CNS mets, chemotherapy may not be that beneficial. That I won't take as a criteria. It generally tells us that it's a bad tumor biology is there. But nowadays we tend to add chemotherapy for all big patients, and definitely if the biologically we feel it's more aggressive, it's better to add chemo in the initial settings.
Rakesh, your thoughts on this slide wherein the benefit seems to be slightly higher with somebody with large volume disease?
So in clinical practice, we really look at volume of the disease in driver mutation positive lung cancer. As long as the mutation is responsive to osimertinib, I don't mind really adding, not adding chemotherapy. Basically, the addition of chemotherapy should take care by the performance status of the patient and brain metastasis. Otherwise, extra CNS metastasis, extra CNS sites of disease, the burden doesn't really make my choice of therapy.
Fair enough. Madam, your thoughts on this?
Yes, the data looks quite promising with the divergence of the curves, and yes, it makes us tempting, but provided if it is a visceral crisis, what you are saying, a large volume disease, yes, chemo can be added. But yes, I would also be tempted to add chemotherapy in a high volume disease, multiple mets with osimertinib with the data. But then low volume disease, single drug osimertinib is good enough for us to continue. So yes, chemotherapy backbone is an important thing, and the graph clearly shows up on your slide.
Dr. Pasi, your thoughts on this? Do you push more for addition of chemotherapy in somebody with a higher volume disease compared to somebody with little less volume of metastasis? Or it doesn't?
And this analysis isn't limited to the brain. This is every site, this is multiple just metastatic sites. It is one of the things I talk to patients about when they have sort of extensive disease, about doing the chemotherapy with osimertinib as opposed to osimertinib alone. But as you saw from my presentation, the lady that had the extensive bone disease, she would have been perfect for combination, but she didn't want it, and yet she had a great response to osimertinib. So it's not for everybody, but I think the data does suggest that there may be more of a benefit if you have a higher burden of disease measured here by metastatic sites at baseline. It doesn't include symptoms, of course, but I think that is one of the clinical features that makes me think about the combination or discuss the combination more with patients.
Fair enough. So I think the data you showed also said that whether the patient has bone mets or liver mets, with or without it, the benefit seems to extend to virtually all patients. So this particular patient declined chemotherapy and went only for osimertinib. Aditya, in your practice, you have discussed chemotherapy plus osimertinib versus osimertinib alone. What percentage of your patients actually refuse chemotherapy?
Sir, a lot of this actually depends on the PS of the patient and the circumstances in which we started the therapy. Quite often, what happens is that whilst waiting for the mutation reports, we end up starting therapy, and then once we have the mutation reports, what I do tell the patient is that yes, there is data for a combination together in a certain particular subset. So although subset analysis is not great, I do tell them that if the disease burden is high, then the chances of having a benefit is greater. In that scenario, I try and convince or lean towards the combination, but more often than not, when we give an option to the patient that they whether take the chemo or not, then they are more often than not inclined to take the chemo. So a lot of it is also dependent on how we counsel our patients, and we should try and use this subgroup analysis to swing the vote either way, sir.
Fair enough. So, Arun, are you by any chance monitoring the circulating tumor DNA? Arun, are you there?
Yeah, I'm here. Yeah, I'm here.
Yeah, are you by any chance started to monitor circulating tumor DNA, or would you want to do it?
Yeah, definitely I would like to do that. The data looks very good, and it will give us an extra advantage also, like we will be able to tell them rather than waiting for the scan to show the progression. But as of now, it's not coming to routine practice for me.
Fair enough. Rakesh, your thoughts on this? The fact that, somebody where it clears the plasma EGFR mutation clearance maybe at 3 weeks, 9 weeks seems to do better compared to where it persists. Your thoughts on this, and have you thought about using this data?
Haven't used it yet, but sir, I think as of now, it is only prognosticating patients, and we don't have to really, we don't have the data to suggest that anybody who is not clearing it well can benefit with the addition of chemotherapy, or either way otherwise. If somebody has cleared the ctDNA, we can hold off chemotherapy. We don't have data for such, adjusted treatments. So as of now, it remains a prognostic marker, and because of intensive cost that adds on to the ongoing treatment, I probably hold off as of today.
Yeah, I think Dr. Pasi did mention that there is an ongoing trial in MSKC, or I think MD Anderson, where they're trying to look at addition of chemotherapy if somebody had not cleared the EGFR. I would like to ask Dr. Pasi's opinion on this fact that baseline plasma EGFR negativity predicted less benefit from the combination of chemotherapy. What's your thought, sir? Why do you think it happened like that?
I think maybe it's a reflection of more indolent disease. Often patients who have just disease confined to the chest don't have circulating ctDNA. And I think if anything, if you don't have baseline on the bottom left, if you don't have baseline detected ctDNA, it's a justification for using osimertinib alone, because the outcomes are quite good there compared to adding chemotherapy adds very little. So it's a good prognostic sign. Having said that, we don't always get it at baseline, and we don't typically monitor it periodically. I monitor it for the to get patients on the trial that I was mentioning, the one that we talked about from MSKCC. And in that example I showed, I also monitored for that reason, because if that lady who had a 27% allelic fraction of EGFR mutation, but it went to 0 after 6 weeks of osimertinib, if it hadn't gone to 0, I would have added chemo or suggested to add chemotherapy to her if she was amenable to that. So, but I don't think it's quite yet ready for routine clinical care. I think there's still clinical trial questions which are being asked in that space.
Fair enough. So I think you did mention that this trial as well, and similar observations were seen. So this particular patient had oligoprogression after 6 months of monotherapy in the bone only. So, madam, your thoughts on this? Lady on single agent osimertinib 6 months down the line develops back pain, and there seems to be progression in one area in the bone. What would you do now?
It's a spinal mets.
Yes, madam.
Spinal mets. Yes, definitely. I would go for a scan to see that PET CT, whether other sites of mets. Okay, single oligometastatic is okay. Should be a good, better prognosis compared to multiple sites of mets. Spine mets, I usually bring in my surgeons for local therapy. If not, radiation holds good for local therapy. Now, as oligometastasis, I will continue osimertinib or whatever treatment I am on and give the local therapy, observe the patient, repeat the scans. If the patient is not symptomatic, not progressing, I would like to continue the same. That is, continuing the same TKI beyond progression, or whatever you say, beyond the oligometastatic site, and do a local therapy there.
Aditya, what would you do in such a patient?
Sir, we live in the cyber knife era, so we do end up. But having jokes apart, yes, I agree with Dr. Anita in the sense that stereotactic radiation and continuation of osimertinib does get us at least another 4 to 6 months, and we have seen that with patients. If we can get targeted radiation to the oligoprogressive sites, we can pull them on the TKI for at least another 4 to 6 months. So it's a very fair option, sir.
Fair enough. Arun, what's your thought about this particular, slide where they said that if you continue osimertinib post-progression, the survival seems to be slightly better compared to, of course, terminating all kinds of systemic therapy, but also when you compared to switching to second-line therapy.
Yeah, see, basically, practically, we don't have much options of osimertinib, no? Like amivantamab and all are a rare patient who will be able to afford that, or will be plain chemotherapy. So this oligoprogression with local therapy, we have been doing it for years now. And because it's basically indolent disease, we'll be able to continue. And we continue also. So I think basically it's a biology. It's an indolent disease, they continue to respond. And once amivantamab becomes more affordable, I don't know, the practice may change. So till then, I think this local therapy and continuing osimertinib is the go-to option as of now, practically.
Fair enough. Rakesh, your thoughts on this osimertinib post-progression, whether it is in 1 or 2 sites or multiple sites?
So if it is 1 or 2 sites, probably like Madam was saying, we should be doing the SBRT to those progressive sites, looking for any ctDNA signals for resistance. If there's no MET or any other targetable mutations, probably if the patient is holding on, continue the osimertinib. That's what I would do, sir. But if it is a frank progression, then probably we have only one chance of getting any response and improving the survival. Go for other alternative systemic treatment, including the ABCP protocol.
Madam, what is your usual choice when somebody has multiple sites of progression on osimertinib?
Yeah, multiple sites of progression, not to continue the drug. Yeah, if options are not available, we usually go back to the chemotherapy. Okay, anyhow, at this point also you need to do an NGS to see that there is any difficult mutation, difficult to treat mutation, or there's a change in the PD-L1 status or anything else. Okay, so that will also guide us. I will discontinue osimertinib if the other options are not available. If chemotherapy not given, systemic chemotherapy is a very good option at this point of time. Again, if we have just seen the Mariposa data, and I think in the last one of these meetings, the data also got published, though the progression-free survival benefit is less, but avimentinib with the chemotherapy in patients who can afford, but where logistics is not there, can be an option in future. But for me, it's just chemo now in multiple metastatics.
Dr. Pasi, in your clinical practice, do you ever consider continuing osimertinib in patients with multiple sites of progression, or you always change to something else?
You typically change to something else in multiple sites, unless multiple is 2, and you can, do local radiation to 2 sites, but typically change treatment. But with a single bone metastasis, I would also do SBRT and then continue osimertinib afterwards.
Fair enough. So just a few thoughts about co-mutations. Arun, your thoughts and your experience with multiple other mutations along with the EGFR which you have picked up. What has your experience been? Say, for example, with P53 mutation along with that, or even an ALK mutation along with that?
So we had patients who had EGFR and ALK, but I think more interesting was somebody with EGFR and BRAF also, where we gave both together, like osimertinib and the BRAF inhibitors were given together, and the patient somehow tolerated it, and almost 1.5 years he survived. So that was after progression. So that again, as Dr. Anita told, the importance of doing a repeated NGS where we'll be able to pick up these things. So, and if EGFR and ALK comes together, so that is like what for that patient we gave only ALK inhibitors, and he responded to that. So that was my experience with co-mutations.
And Dr. Rakesh, your thoughts, sir?
So I think my experience with co-mutations, sometimes we have seen complex mutations. The de novo T790 plus other deletion or the substitutions or one of those uncommon substitutions. And most of the times the response has been muted, and most of the times PFS has been around 20 to 30% lesser than the clean mutations of deletion 19 or L858R. There is more motivation to add chemotherapy in addition to the ongoing TK therapy. And again, they tend to be having more smokers. They tend to be having more male patients. This is one of the anecdotal experience that I'm sharing, not to quote that it is scientific or anything like that.
Fair enough. I think good points, Rakesh. Madam, your thoughts and your experience when somebody has had multiple mutations?
The co-mutations, yes, is now emerging, and that's what the NGS will let us know. Okay, one osimertinib, if it is like ALK ROS mutation, you add the ALK inhibitors, or the ROS is the same crizotinib. Next is, if it is another co-mutation and the patient has progressed, then afatinib is a drug which acts on atypical mutation. Though the results are not very good like osimertinib, afatinib is a very good choice for atypical mutations. Otherwise, chemotherapy is my choice. Okay, and we have to wait for more of these like KRAS. We have a drug available. Metexon skipping mutation. I had one patient, we started with Tipod. It depends upon what mutation you get. If it's a dominant mutation, you add that particular drug. Otherwise, nothing is, if many of them will be due to logistics, patient may not, then give generic afatinib. That's a good drug to continue in atypical mutations. And a third line will be straight away switch on to chemotherapy.
Aditya, in your practice, upfront patients with co-mutations?
Sir, anecdotal evidence to suggest that we can use both EGFR and ALK TKIs together. I have used it in a couple of patients. They have tolerated reasonably okay. It's tough to pick one over the other because we don't know. Sometimes we may want to look at the VAF or the NGF report a little bit closer. Talk to our molecular pathologist to find out which of them is the driver, but those scenarios are quite rare. Actually, more commonly are the possibilities of having one driver mutation and one non-driver mutation. And in that scenario, I think I agree with all my other esteemed experts here that chemo with TKI is the way forward.
Fair
Definitely
enough.
no immuno here. No immuno here, yeah.
Yeah, Dr. Pasi, your thoughts on other co-mutations, and also specifically, I think all of us have had quite a few patients or at least some cases where EGFR, ALK, both are positive. How have you dealt with it?
Yeah, so if at the time of resistance, I see MET amplification or an ALK rearrangement, I would add a therapy targeted at those. We commonly use capmatinib for MET inhibition with EGFR. For ALK, I have not, but there are individuals in my group who have added alectinib to osimertinib, for example, and that does seem to be well tolerated. In the absence of a mutation at the time of resistance, chemotherapy would be the standard of care. If we use chemotherapy, I typically don't stop somebody's osimertinib. I keep their osimertinib, especially if they've had CNS disease, and then add chemotherapy. However, more recently, given the Mariposa 2 trial, we've switched a lot to giving amivantamab in chemotherapy following progression on single-agent osimertinib.
Fair enough. So I think we will last 5 minutes and we will quickly discuss the adjuvant use of osimertinib. So this is a 50-year-old lady presented with right upper lobe lesion, underwent surgery and EGFR exon 19 mutation. Arun, in your practice, these patients would come for chemotherapy or chemotherapy plus TKI or TKI alone. What is your thoughts?
So basically, if they are high risk and post lung cancer surgery, most of the patients I prefer to give them chemotherapy and then maybe adjuvant if the EGFR mutant, complete the adjuvant treatment afterwards. So it will be a combination of both. I may not combine chemo and chemo and the EGFR initially, but maybe chemo first and then give them 2 years of osimertinib or osimertinib later.
Fair enough. Dr. Rakesh, in your practice, how do you manage these patients?
So in stage 1B, sir, I think we need to really look into the multidisciplinary management. We need to discuss this patient in the multidisciplinary tumor board with molecular pathologist, our pathologist, and ourselves, putting our thoughts to that. And 1B, not all require chemotherapy. And in 1B, probably we look at the high-risk features, poorly differentiation, PET uptake. And one of those high-risk features are there, then probably they go for chemotherapy. If in the presence of EGFR mutation, I will be tempted to stop off, in the presence of high-risk features, probably I'll be tempted to stop not give chemotherapy and go for osimertinib. But again, it's a difficult choice. 1B is again a very ambiguous choice for chemotherapy as well. Anybody who deserves chemotherapy will probably go on to receive osimertinib in my practice.
Fair enough. Madam, your thoughts on adjuvant osimertinib?
Okay, adjuvant osimertinib now I think become the standard of care. Stage 2 and 3A resectable tumors. Yes, with mutation, I will do 2 tests. One is the EGFR mutation, and I will also do the PD-L1. So we have drugs for the PD-L1 positive adjuvant, and with the aduratide, even in stage 1B, I will be tempted to give 4 cycles of chemotherapy and osimertinib adjuvant. Results are too good, and I would like to continue.
Aditya, you also would do chemo followed by osimertinib or only osimertinib?
A lot of it actually depends on the post-operative fitness of the patient. Almost, I don't know how many of patients for our colleagues are able to do, but in my practice, 30-40% of them are probably not even fit to receive adjuvant chemo after undergoing a major resection. So in that scenario, I think the decision becomes easier. However, if patients are fit for both, then I would like to sequence chemo first and then osimertinib, sir.
Fair enough. So I think let's have a final thought.
Sorry to interrupt, sir. 2 minutes left, sir.
Yeah. So this is a final slide. I just wanted the final thoughts of our speaker on post-osimertinib, relapse and how he deals with that patient. And that was the last question from my side.
Are we talking about after
Yes,
adjuvant therapy?
Absolutely.
Yeah. Typically, monitoring, I do CT scans every 4 to 6 months for the first couple of years, and then space it out if everything looks good. If a patient relapses after completion of adjuvant chemotherapy, adjuvant osimertinib, then I would restart that person on osimertinib because it's likely that that was a scenario where there was a tolerant population that was able to survive osimertinib and then started to regrow. So if you retreat him, it's probably sensitive again, like it would be in the first-line metastatic setting. If someone progresses on adjuvant osimertinib during the time of drug treatment, then it's like progression on first-line osimertinib for metastatic disease. And there I would go through the rebiopsying and trying to understand, is there a resistance mechanism, et cetera, kind of what we talked about for advanced cancer.
Fair enough. So I think to summarize, we know that I think EGFR diagnosis of EGFR positive lung cancer and the treatment of such patients has really changed over the last few years. And I think we are lucky to be in this era where so much of specific treatment has come into the picture. I thank AstraZeneca for this opportunity, and I thank all the panelists for this wonderful discussion and hand it over back to the organizers. Thank you.
Thank you very much, Dr. Krishna Prasad. It was really an interesting discussion, very interactive discussion. Just 2 minutes, there were 2 questions in the chat box. How to manage oligoprogression for patients on TKI plus chemo combination, I think that was taken up. And oligoprogression at inaccessible site management, I think that was probably for biopsy, maybe that is why it was asked. Anyway, I think these questions have been asked in the discussion. And another question, can we use osimertinib in brain mets without T790M? Dr. Krishna Prasad, could you take it?
We will ask Dr. Aditya this question. This has happened multiple times, and it will continue to happen in our clinical practice, where we probably will use first generation or second generation TKIs, and patient has progression only in the brain. Aditya, what's your thought? Such patients, would you think about just osimertinib, because that's probably the one drug which enters the brain?
I don't see Dr. Aditya.
Arun, can you take it? Dr. Rakesh? So I think I'll answer that, madam. I have used osimertinib in that situation. Basically, a situation where we use first or second generation TKI. Patient progresses after 1.5 years only in the brain. In those patients, I do discuss even when T790 has not been picked up on liquid biopsy. Yeah.
Yeah, and I would agree that with that approach as well. So thank you again for inviting me today. I enjoyed the discussion and the questions, and hope all of you have a good weekend.
Thank you, Dr. Pasi. Thanks a lot.
Thank you all for your insightful contributions and active participation today. And our discussions about the latest evidence, debated controversies have highlighted the available options, challenges in treating EGFR mutated lung cancer, especially the metastatic disease. So thank you one and all. And thank you very much, AstraZeneca, for having us enjoy this wonderful discussion today. And I hand over to AstraZeneca.